Hello, everyone, and welcome to another episode of the Tokyo Living Podcast Injury Edition. Today, we are going to be talking about tendons. We're going to be going over the basics of what they are and why they sometimes hurt. We will be discussing a series of conditions that people may know of as tendonitis or tendinopathy or tendinosis, and we'll be talking about specific conditions that some people may not recognize as tendon conditions, such as a tennis elbow or golfer's elbow, and we'll also be going over some other common sites of tendon injury, such as the Achilles, the patella, the lateral hip, and the upper hamstring. Now, we won't be talking about the rotator cuff, even though this is a tendinopathy. It is a much more complex condition. It's a different beast, if you like, to some of the other tendon injuries that we see. And we'll actually be dedicating an entire podcast on rotator cuff related pain next month. So you've got that to look forward to, but we won't actually be covering that in this particular episode. So we'll start by talking about what a tendon actually is. Now, some people may remember from anatomy in school that a tendon basically attaches a muscle to a bone. And that's basically the structure. It's there to allow that attachment from the bone to the muscle. And there are a number of different lengths and sizes of tendons in our body. So some muscles will have the muscle essentially attaching straight onto the bone, whereas others will have a very long tendon where most of the structure will actually be more of a tendon and with only a very small muscle belly. But essentially, the job of a tendon, if we take my arm, for example, we have the muscle belly here, and if I want to bend my elbow, we have the muscle contracting, which then pulls on the tendon, which then pulls on the forearm, the closer aspect of the forearm, to allow that bending to occur. So that is anatomically where a tendon lies within our musculoskeletal system. Now, why don't we just have the muscles attaching straight onto the bones, I hear you ask? Whilst that may allow for the same force and contractile element to cause movement at the joints where those muscles lie, one of the main functions of a tendon is in what we call load or energy storage and release. So in that regard, a tendon essentially acts as a spring, and it does this best during faster tasks, what we call high tendon load tasks, something like running or jumping, or something like hitting a tennis ball, and obviously we'll get on to talk about tennis elbow in a little bit. But when those sort of activities take place, let's take running, for example, or even jumping, as our foot hits the ground with every step that we take when we run, our calf muscles have to contract. And they essentially, there's a little bit of lengthening through the muscles, but they're essentially contracting what we call isometrically. So there's not a lot of change in the actual length of the muscles. So the muscle contracts, and a lot of the energy is actually absorbed in the Achilles tendon. So the Achilles tendon is the tendon that attaches two of the main calf muscles from the foot to the lower leg and the upper leg, where those two muscles attach respectively. So those calf muscles contract. The tendon basically allows that energy to be stored as you hit the ground, right, and then released like a spring. So when you take off the ground, that tendon allows that energy to be released into the limb, to allow us to move through the ankle and to allow that force production and that propulsion in that gait pattern. The same thing if we were to hit a tennis ball. Let's say we're doing a backhand. As we come in contact with the ball, our wrist isn't really moving too much, but the muscles that cause the wrist to move into extension, so going this, if you're watching the video version of this, if the wrist moves this way, that's what we call extension. The wrist isn't really moving that much, but those muscles are contracting. And then as the moment that we hit the ball, there's a very high tendon load. So the tendon comes under a great degree of stress. It absorbs that energy and then releases. And that's where we get a lot of the propulsion in those sort of activities. So this is a fantastic system. This is a very well designed system of the body, and it allows us to participate in the huge array of athletic tasks that a lot of people like to do, but also allows us to perform many of our day-to-day. So while walking isn't necessarily what we would think of as a high tendon load task, we are still having to rely somewhat on the energy storage and release of the Achilles tendon, so that all the work isn't having to be done through the calf muscles. And the same can be said about all the tendons in our body in relation to different tasks. So the problem occurs, though, is when we overload the system, when we overload these tendons. Now, a lot of what we talk about in terms of the cause of tendon pain and the diagnosis and the management all revolves around the concept of load, which we covered in a previous podcast. So if you want to get the most out of this episode, it's probably worth going back and having a listen to that and getting an idea of what we talk about when we talk about load and the different types of the load that are placed on the system and how this relates to pain. When we talk about tendon load, we're talking about that direct tissue-specific load. So the actual load that is placed on the tendon, and that is the main driver of tendon pain. So when we apply too much tendon-specific load, the tendon starts to react, and once it's overloaded, has the ability to produce a painful experience. So as we go through talking about why we get tendon pain, we'll also talk a little bit about the language that's used in regards to tendon-related conditions. So when we overload a tendon, we can get a painful response. Now, we used to refer to this condition as tendonitis. And this term is still somewhat prevalent in certain areas of medicine, but it's a term that in the rehabilitation world we've tend to move away from. The term itis, or that postfix itis, as many people know, is related to inflammation and is used in conditions where the inflammation is the primary driver of the negative effects of the condition or the symptomology. So, you might have something like a prostatitis or a tonsillitis, appendicitis. All those things are inflammatory conditions, and the inflammation has a major role in symptomology. And when we think about itis-related conditions, the treatment modalities are generally ones directed at inflammation management. So this might be, in the case of a musculoskeletal condition, relative rest or complete rest to allow that inflammation to settle, or with musculoskeletal conditions, but also with a lot of other medical conditions, it likely involves the use of anti-inflammatory pharmacological intervention. What we've found, though, with tendon pain is this isn't really an effective treatment strategy. And it's also the fact that the inflammation isn't the main driver of pain when we get a tendon-related condition. We went through a period where we had studies showing that there was no inflammation related to tendon pain. The latest research shows that there may be some tendon related inflammation that people with tendon pain experience, but is unlikely to be the main driver of pain. What we now understand about tendon-related pain is that it is a cell-driven process. So when we have an overload, now when we talk about overload, as you'll know if you've listened to the previous episode on load, this may be overload over the course of, say, a month. So if you increase, say, your running volume too quickly over the course of maybe 4 to 6 weeks, then that may place a direct tissue-specific load or direct tissue-specific overload on the Achilles tendon. Similarly, you might have more of an acute overload. So let's say you usually play an hour of tennis a few times a week, and then for whatever reason, you may have been invited to a number of different games, and you end up playing 3 hours of tennis at one time. Then you've increased your load on that particular day by 300%, and that has caused an acute overload. Both of these conditions can lead to overloading of the tendon. Now, in that case, we get basically an excessive production of repair cells. So the body senses that there has been some overload in the region, so it sends all these repair cells and in particular proteins called proteoglycans to the area. And this is what actually causes what is often observed as a thickening of the tendon. So it's not a strict inflammatory process that you would experience. Let's say if you rolled your ankle badly and the ankle sort of blows up and gets very inflamed, what's happening in the tendons is very different. So you have these proteoglycans that go to the tendon, and because of the presence of these structures, they're osmotic, they draw in water, and as they draw in water, they start to cause that sort of puffy, thickened presentation. Now, if we have prolonged tendon pain or prolonged excessive loading for a tendon, then we may start to see actual structural changes occur. And so, the arrangement of the collagen starts to become, less neat, if you like. We have an increased cellularity around the tendon. We can have an increased vascularization and an increased ingrowth of nerves and also neuropeptides. So the area then becomes more sensitized. You have more nerve endings there to transmit messages of potential threat and danger up towards the brain and the central nervous system, which can predispose us to the likelihood of a painful experience. And this is generally what is referred to as a tendinosis. So when we actually get a change in the structure of the tendon. Now, although that might be structurally a more accurate representation of what happens when we have ongoing tendon pain, it's still not a particularly useful term. Most tendon problems can be diagnosed without the use of imaging, and even when we scan normal populations, so even people that haven't had tendon pain but have done a lot of high tendon load activity. So let's say you're a basketball player or a volleyball player, and you've done that your whole life, but you've managed your load in such a way that you haven't had these periods of overloading. We might still find that if we ultrasound or image the patellar tendon, so because those sort of sports are very hard on the knees, we may still see this tendinosis occur, even though that person has been asymptomatic. So the findings of imaging don't necessarily relate to what we're seeing clinically. And because of that, doesn't necessarily influence our management and our treatment plan. So again, tendinosis is not really a term that we use either. So we have this term tendinopathy, which essentially just means a pathology or problem with the tendon. And that might sound like it's very generalized and a broad description, but even when we use these broad descriptions, we can still be extremely individualized with where someone is in terms of the stage of the condition, what brought it on, the types of load, and we can still be very individualized with our management strategies. Going a step further with the tendinopathy, there have been other labels that have been placed to differentiate different stages of the condition. The most widely recognized one is the tendon continuum model, or tendinopathy continuum model, which was proposed by Jill Cook and Craig Purton towards the late 2000s. And within this model, they describe a tendon as being a reactive tendinopathy, which is sort of what we described earlier in terms of that acute onset, that acute presentation. Then a next phase, which they described as a disrepair or failed healing stage. And then that progresses then into a degenerative tendinopathy. And so whilst we do use that model to a certain extent in terms of trying to work out where someone is within their presentation of tendon pain. So if someone is in a very acute stage, if they've gone out and they've done way too much activity or too much of a certain sport, and they've flared up their tendon, then our management will be focused on trying to settle the tendon down. So we're not going to apply too much extra load. We'll be unloading using modalities that we'll discuss later. And usually we can get on top of these if we can manage the load, take out the high tendon load. And this doesn't necessarily mean stopping training. It may just mean some modification of training and using some other adjuncts to try and settle the tendon down. If someone has had the tendon pain for a lot longer, which in all honesty, in a clinic such as ours, a general outpatient physiotherapy practice, that's more of what we see. We tend not to see these reactive tendinopathies. It's more the later stage issue. Our focus then will be more on building up the capacity of the tendon to handle the load that is placed through it. And so while we do use that model to a certain degree, the terminology is not something that I necessarily use, and especially not with a patient. So terms like disrepair or failed healing or degenerative, we tend to try and take those terminology, those sort of negative terms, out of our practice, unless they are necessary, unless the use of those terms is going to advantage the patient in some way. So I will tend to think of a tendinopathy as an early stage or mid stage or later stage, and then apply the appropriate interventions based on that staging. Now, some other things that can happen with the tendon. So we talked about the tendon attaching bone to muscle, muscle to bone, and when the muscle contracts, it pulls on the tendon, and that tendon acts as a spring. So that's what we call tensile loading, and that is one aspect of the loading that occurs with the tendon. The other type of loading that occurs is what we call a compressive loading. Now, the tendons and the sites of the tendons where we tend to get pain, and this is more so with certain tendons, and we'll talk about this in a little bit, but they're often in areas that get compressed. So, for example, if you have an Achilles tendon, and if you're watching the video version, you can see an image here. The calf muscles attach onto the Achilles tendon. The Achilles tendon comes down the back of the leg and attaches into the back of the foot, but it sort of wraps around that back of the foot. So when you bend your ankle up, so you bend your toes up towards you, you're obviously lengthening the calf muscle and the Achilles tendon, but you're also increasing the amount of compression around that bottom part of the Achilles. And in most tendon conditions, in most tendinopathies, it's the insertion where we experience the pain. The Achilles is actually the exception. We have insertional Achilles tendinopathy, but we also have a mid-portion Achilles tendinopathy. And they are, in some ways, quite different conditions, and we do treat them slightly differently. But for a lot of the tendons, we see the painful spot around that area of compression. And obviously that compression is normal. Our bodies were designed in that way. We need the tendons sort of wrapping around the bone to a certain degree so that when they contract, they have a rotational leverage and they're able to pull the bones in the direction that we want them to. However, again, if we have an excessive loading, then the areas that are vulnerable to compression also being put under that same tensile load. So we're getting contraction of the tendon, but we're also squashing it at the end. And what happens in that case, if that happens for too long, we get a change in the type of collagen that's present in that area. So the body senses compression or excessive compression as a need to provide structure that buffers that compression. So you think about the areas of the body where the compression is greatest, in our sort of big weight-bearing joints like the knees and the hips, we have a ton of cartilage there, or most people do. I don't, but that's my own fault. But most people will have a lot of cartilage in their knees to buffer that compression. And so when the body senses other areas that might be under an excessive degree of compression, it sort of tries to create a pseudocartilage. So instead of a constant production of what we call tenocytes, which are basically the cells that make tendons, we start to have what we call chondrocytes. So we have more of a shift towards these cartilage-like cells, and they're really robust for compressive loading, which is great. But unfortunately, they result in reduced tensile loading capacity of the tendon. So once we start to get those chondrocytes forming, and it's less of a springy type of substance, it's stiffer. Now, we do want the tendons to be stiffer, and we'll talk about that in a minute when we go into treatment. But we don't want them to be stiff and rigid in the way that a chondrocyte will cause a tendon to become. So that's basically what happens structurally when we get a ongoing loading to a tendon that may result in pain in that area. Now, there are some other changes as well. So we do have a change in a cortical inhibition. So when we're going about our normal day-to-day function, our brain, our central nervous system is on constant alert for things that might be going on. We're always getting information from the periphery up to the brain, and the brain is just working out the whole time whether we're in a good sort of state of homeostasis. And if we sense that there might be something wrong, it goes through this very complicated filter, and if we perceive that we're in some sort of danger, then we'll get pain. And it's what we find, and this is the same with a lot of different pain types, but when we have tendon pain, we get a change in that cortical inhibition. So most of the time, if something isn't too much of a problem, we can sort of shut those messages down to a certain degree. But when we have ongoing pain, the ability of our nervous system to shut that pain down is then diminished. And that's sort of a secondary response that can happen in response to excessive loading on the tendons. Now, how do we diagnose a tendon? For the most part, it's really easy. Most people, from their presentation, what they describe, they will usually describe an episode of acute or ongoing overload. And they will point to the area of pain, and usually it's quite localized. So tendon pain, for the most part, doesn't usually spread too far. So it's usually localized to an area of sort of 2 fingers palpation width, if you like. And they would usually describe that the pain is worse with higher intensity activities. So they might be okay with walking, but when they start to run, they might be a little bit painful, if we're talking about the Achilles, for example. And then if they try to jump or do something like that, then the pain increases. Sometimes tendon pain will sort of go away once warmed up, but then will come back stronger afterwards. But often the longer a tendinopathy progresses, the less of that pattern we have, and we'll get more of a pattern of it actually getting a little bit worse during activity as well. When we go through an assessment, we will go through certain movements that put that tendon under load. So let's take the easiest example of the Achilles tendon. We might start with a 2-legged calf raise from the floor. We might then progress to a single-legged calf raise, and we might see an increase in pain from 2 to 1 leg, and then we might try some hopping, and that may show a further increase in pain. And that's where we know that we're starting to look towards a tendinopathy as a possible diagnosis. Then we would palpate the area, and usually we can elicit palpation or elicit pain with direct palpation and direct sort of touching and poking around that tendon. And that's basically what we use to diagnose the tendinopathy. And obviously, we want to try and exclude other causes of pain. And there are some systemic inflammatory conditions that may present as tendon type pain, and especially if people have tendon type pain, and especially insertional tendon type pain in multiple areas, then we're starting to think that this may be a systemic inflammatory condition, which would lead us down to further investigation and possibly imaging and blood work and things like that. Another condition that we might see, which again is most common in the Achilles, is what we call a peritendinitis. And this is a group of conditions which may include a tenosynovitis, a peritendinitis, and a tenovaginitis. And these are basically an inflammation of the surrounding area, so the sheath that covers the tendon. And these behave differently. So let's say we do a calf raise on 2 legs, a little bit of soreness. Calf raise on 1, it's about the same. If there's no sort of increase, and then we do a bit of a hop, and it's actually not that much worse. But when we go through that full range of motion, and even if we do that passively, where there's no real load on the tendon, we're just moving it, and that's causing pain. And especially if we see some focal swelling over the area, and combined with what we call crepitus, so that creaky sort of sound, then we're starting to think that it's more of a peritoneum issue. And this might be, for example, in a cyclist. So cycling is not really heavy tendon load. You're not sort of getting that contraction, that spring-like action of the Achilles tendon. You're keeping your feet in the pedals. It is high load in terms of muscular load, especially through the thighs. but it's not really putting that much load on the tendon, but it is a repetitive movement through the tendon. And it's that repetitive movement that flares them up. And so in this sort of presentation, we'll go on to treatment in a second. Our main treatment for tendon pain is loading. For something like a paratendon issue, that can actually make things worse. So that's where an accurate diagnosis of the problem is really key. Like I said before, imaging is not really helpful in the diagnosis. It doesn't really add anything to the diagnosis, and it's just really unnecessary. We should be able to make a diagnosis of a tendinopathy through a basic clinical examination. So how do we treat these painful tendons? Like I said before, it depends on where the person is in the stage of their tendon problem. So if it's a fairly new issue, if it's come on fairly recently, then our priority is to try and control pain. And that's where we will be more aggressive in terms of limitation of certain activities. So it may be for some people that we need to take them away from their activity completely, depending on how severe the symptoms are. For others, it may just be a modification of load, so either a decrease in the volume or intensity of the activity that they are doing. We can do some strengthening work in this stage, but what tends to be most effective in terms of addressing the pain associated with the early stage of a tendon problem is static hold, so what we call isometric contractions. So an isometric contraction of my wrist is basically, just pushing up against the resistance of my hand. So it's not moving, but I'm still contracting the muscles that attach onto that tendon. And so that can be really useful in settling down symptoms. And even if it's a little bit painful to do, we'll often find that with repetition, it gets less painful. Where we have most of the evidence for this type of approach is in the knee, in the patellar tendon. But through our sort of clinical experience, we've found that isometric contractions can be effective for other tendons in the body. As a tendon progresses, our focus is more on building the capacity of the tendon to handle the loads that we're placing on it. So this is where we really go into the crux of tendon management. So when we load a tendon, so when we contract the muscles around it and apply a certain degree of loading to that structure, then we can actually change the properties of that tendon. We can increase the stiffness, which for most people, when they hear increased stiffness, they associate that with perhaps a poorer outcome in terms of musculoskeletal conditions, which that is a whole different sort of debate and podcast episode in its own right. Not necessarily the case, but particularly when we're talking about tendons, we want them to be stiff, because remember, they need to function as a spring. And if we have a really loosey-goosey spring like a zinky, that's not going to produce much force. All right, we want that spring to be stiff and to be able to produce force. To do this, though, we actually need quite a strong amount of load. So studies have shown that we need sort of 70 to 90% of maximal contraction to actually stimulate this stiffness, and it needs to be applied for a relatively long time. So we're looking at programs of around 10 to 12 weeks. This isn't something that changes in a week or two. We actually need to have a prolonged stimulus for these changes to occur. And this approach we call mechanotherapy. So it basically just means using mechanics, using movement as a therapy, as a injury intervention, rehabilitation intervention. What's actually happening when we're loading is called mechanotransduction. So again, that's just the mechanical stimulus, the movement triggering a stimulus that then results in an adaptation. When we get this trigger to the cells, now this can be by shear force, so tensile force or compression. And even if we just stimulate one or two of the cells within the tendon, we get this cross-communication within the cells, and it has the ability to affect the thousands of cells within that sort of matrix that is in the tendon and makes up the tendon fibers. And so this initiates the cell nucleus to you start the production of new proteins, and we start to get a change in the tendon that way. We're getting an increase in growth factors and cytokines, in particular insulin-like growth factor 1. And we also get a remodeling of the neurons within the tendon. So I talked before about that invagination of the nerves into the tendon, we can get some restructuring of that, which will then set us up to be less sensitive. There's less of those active nerve endings that are sending messages up to the brain. And we get a desensitization in the tissue. So basically, when we're contracting a tissue, we're decreasing the sensitivity associated with that contraction. And we're also, changing some of the processes in the brain as well. So we're starting to recover some of that inhibition that occurs. And we're improving the central nervous system, the brain's ability to dull down some of those messages that we're getting from the periphery. So that's sort of the crux of what happens where, and that's sort of the science behind loading. More important, as a clinician, is sort of the art and around how we do that. When we're dealing with tendon problems that are primarily caused by the compression element that we discussed a moment ago, then we need to take some of that compression out. So if someone has an insertional Achilles tendon problem, when it's sort of on the base as it wraps around the foot there, then we may have to lift the heel. So have that person walking with a heel raise in the shoe, so they're not getting that same amount of compression. And what we need to start strengthening, we might start strengthening a calf raise with the heels starting elevated. So rather than, if you've done calf raises before, dropping over a step, instead of that, we might start with the heel actually elevated. So it's a shorter range of motion. We're still getting that mechanotransduction through the tendon, but we're doing it in a position that doesn't cause that same level of compression. If we're dealing with a proximal hamstring, so that upper hamstring is an area people don't usually associate with a tendon problem, but we do often see tendon-related pain there, particularly with people that are doing a lot of hill running, things like that, or doing a lot of resistance training that involves that hip flexion, that loaded hip flexion, deadlifts and squats and things like that. So for those people, we may need to have them do strength exercises for the glutes, but avoiding loading into that that position. So modified range squats, modified range deadlifts, things like that. We need to start with heavy loading, and we need to start at a level of pain and a frequency of loading that doesn't provoke symptoms. Now, in general, tendon management, exercise for tendon pain doesn't necessarily need to be pain-free, although some areas will respond better to a painful or allowing pain with rehab than others. In general, the lower limb tends to be a little bit more robust, and that sort of makes sense when you consider the loads that are going through our lower limb on a daily basis. But those areas tend to respond a little bit better to a rehab strategy that allows pain, whereas the upper limb, so your tennis elbow and tennis and golfer's elbow, those sort of things, they tend not to respond quite as well to that painful management. So we've got to find out where we can start our loading, the type of exercises, the modality, the range of motion, and how often, whether it's 3 times a week or daily, we can load that tendon up, but not have it be worse the next day. So if things are worse the next day, or particularly if things are worse 2 days later, that's a sign that we're doing too much. So we need to back off on the loading and try and find that sweet spot where we're able to load the tendon, but we're not getting an increase in pain later. And then we basically progress through. So we want to get a strong base of strength through the muscle that attaches to the tendon and the tendon's ability to tolerate load. From there, we want to start to progress towards faster loading. So we talked before about how the tendon's job is to store and release energy. And it does that the most when we're doing higher speed activities, so running and jumping and things like that. So we need to build up our program to include those sort of activities before we return to sport, if we are returning to sport that involves those type of contractions. So we need to progress to things like hopping and jumping and those type of exercises. However, we still need to keep going with our strengthening exercises. So a strengthening exercise, again, for an Achilles tendon might be a really heavy calf raise over a step if it's not a sensitive insertional tendon problem. We might be using some weights so that we're really getting good loading through that tendon. We need to do that to keep promoting the changes, because whilst hopping and jumping is necessary as a bridge towards getting back to our eventual functional goal, it doesn't actually, it's the heavy loading that actually changes the structure and the stiffness of the tendon. And it's important that we keep that going throughout our rehab process. Other aspects of treatment. So as with anything, we need to address the biomechanics. So, for example, if I have a tennis elbow and it may have been caused by some shoulder range of motion deficits, or it might be that I don't have sort of sufficient trunk strength and stability, then we need to include those sort of elements within our rehab program as well. Similarly, technique, if you have a technique that's putting stress on certain areas. Let's say, again, we'll use tennis as an example. I have a tennis elbow, and there's some issues with, say, the top spin that I'm putting on my strokes with tennis. Then that needs to be addressed again in order to decrease some of the load on the tendon. So it's sort of a two-way process. We're trying to do things that will decrease the load on the tendon, but at the same time, we want to work on that tendon's load specifically to increase its tolerance to loading. In running, we might make some changes to the gait pattern. So we might make some changes to the way that someone's running, even if it's just in the short term, to try and allow us to get that activity in without limiting activity, but with doing so with less pain. We might use things like orthotics. We might use taping to try and offload the tendon. And then we may use other more passive modalities, such as soft tissue techniques, some massage, mobilization. Personally, I like to use mobilization with movement and teach people how to perform those sort of mobilization movement techniques at home, so they have their own sort of analgesic, their own pain relieving exercises to use to try and manage their symptoms when they're outside the clinic. When it comes to more invasive procedures, injections in tendons, the traditional injection in a tendon was a corticosteroid injection, and we have a previous episode all about injections. If you want to go back and hear my thoughts on the different type of injections that we use in musculoskeletal medicine, please go back and have a listen to that. But when we talk about tendons, steroid injection doesn't usually have a good long-term outcome. It has been shown to decrease pain in the short term, but can actually increase pain when we sort of look a year or so down the track. And it may increase the likelihood of rupture. And we certainly don't want a tendon rupture, particularly in those lower limb tendons, something like an Achilles tendon. Once you rupture an Achilles tendon, that's a really long rehab process, and we don't want people to go through that. The other types of injections that might be used, people may have heard of the blood injections, particularly things like a autologous blood injection, or more recently the PRP, the platelet-rich plasma injection, where they basically take your blood, spindle out that rich plasma, and then inject it back in. And this is thought to have a healing effect. It is very popular, and we certainly know a lot of people that have had positive outcomes, but the research still doesn't strongly support its use in tendon pain. One of the other commonly used adjunct treatments for tendinopathy is what we call extracorporeal shockwave therapy. So this is basically where shock waves, which are very specific sound waves, are blasted into the tendon, and this is thought to have an effect on the vascularization at where the tendon joins onto the bone. It can stimulate those tenocytes that we talked about before, that sort of help make up the tendon. And is also decreasing some of the neural sensitivity in the area. So you're almost sort of blasting some of those sensory nerves. And it has been shown to have somewhat good results in terms of pain relief from tendinopathy. So in comparison to an injection, we certainly think that this is perhaps a better option, and it's certainly gaining a lot in terms of popularity. But especially in Japan, it is still an expensive treatment. It's not covered by either Japanese insurance, and depending on certain insurance companies, not under international insurance as well. So is the cost factor. It can be painful, and it doesn't always work. So we always sort of save that for more of a latter stage resort. And then there is tendon surgery, which, to be honest, we don't really see a lot of, and it's being performed less and less now, because generally the outcomes aren't any more superior than our sort of non-operative management strategies, and the rehabilitation is a lot longer, and there's all obviously the other associated risks that come along with any sort of surgery. So that's sort of the way that we go about approaching tendons. And when we talk about different types of tendons in the body, we've sort of talked a little bit about the Achilles and how we might modify our tendon loading. Like I said, the lower limb can usually tolerate a little bit more pain with our loading. Things like heel raisers and orthotics and taping can be useful in terms of offloading the Achilles. And if it's a running issue, we can make some modifications to the running gait. And we would address all biomechanics as well. So there might be some weakness further up the chain. So we might have some quads weakness that's causing more stress on the Achilles and that calf complex, and we would address that. Those sort of strategies can be useful also for a peroneal tendon injury, which is basically the peroneals are the muscles on the outside of the leg that run down and turn the foot outwards, or on the muscles on the other side that turn the foot inwards, which are primarily your flexor hallucis longus and your tibialis posterior. Both of those, they're on opposite sides of the foot, so they're not things you're going to get concurrently, but both of those tendons may respond to, in addition to the loading strategies that we've talked about before, things like orthotics or taping or gait modification, in addition to our strengthening work. Let's come up to the chain, things like patella tendon. So the patella is the bone, the kneecap, and the patella tendon is where the quadricep muscles attach onto the front of the shin. And when the quadriceps contract, they pull on the patella tendon, and that straightens the leg. And that is susceptible to injury with high tendon loading, such as jumping in volleyball and basketball and sports like that. And so those sort of conditions respond quite well, like we talked about before, to isometric static exercise in the early stage, and then sort of progressive loading from there. A common source of tendon pain in sort of middle-aged women is, and it doesn't occur solely in middle-aged women, but we tend to see it a lot in this age group, is lateral hip pain. So this has been known as a greater trochanter pain syndrome, or gluteus medius or gluteus minimus tendinopathy, and was previously commonly known as bursitis. So people would often complain about a bursitis on the side of their hip. And again, that itis part was associated with an anti-inflammatory directed rehab strategy. So a lot of injections, ice, anti-inflammatories, that type of thing. But we now understand that it's more likely to be the insertion of those two muscles, the gluteus medius and or gluteus medius tendons, onto the side of the hip, in an area that, there's a very busy area. You have your iliotibial band, or the ITB, that people may have heard of, that sort of goes over that area, and it sort of squashes everything together. And the bursa may be involved, but typically it's a problem of compressive tendon loading. What we find with this type of condition is that education and addressing activities of daily living can be really useful. So getting people to decrease the amount of time that they're sitting with their legs crossed, or sleeping with a pillow between their knees. So basically anything that's preventing or decreasing the amount of movement of the leg over, the midline. They found that even if you bring your leg 10 degrees across the midline, it increases the pressure under the ITB by 9-fold. And then if you're bringing it to end range, it increases it 25-fold. So even slight strategies to decrease that amount of compression can be really effective in this condition. And obviously from there, we sort of work on hip strengthening. Often hip sort of weakness and lack of control can be causative of this. So we work a lot on developing that strength and control through the hip muscles. When we go around to the back of the hip, we've talked before about that proximal hamstring tendinopathy. So where the hamstrings come and attach up onto the top of the pelvis, that can be really susceptible for overload if we're doing a lot of bending work, as I talked before about hill running, strength work with deep bends. And this can be a really slow condition to improve. And it's usually based around optimizing the load and decreasing that bending load to start off with, and gradually increasing the load from there. Sitting posture can be relevant as well, especially if we're sitting on a hard surface. That consistent pressure on that area can aggravate the tendon. So we may opt for a softer sitting surface, or even an area that's sort of, we've got a bit of a hole under the area, so it's not in direct contact with the sitting surface while we're sitting, or just trying to increase the amount that we're standing throughout our workday. We're coming up into the upper limb. The most common tendon issues we see up here are our golfers and tennis elbow. So these conditions aren't solely attributed to by these respective sports, and we can see a tennis elbow come on in golf, and we can see a golfer's elbow in tennis players, and we see both those conditions in a lot of other athletes, and a lot of just day-to-day function, excessive function, bringing these conditions on. There may be some taping and bracing techniques that we use to try and offload the specific tendon load early on. And then it's basically a progression of local load to the tendon, but also working on other aspects up the chain. So things like shoulder strength. And sometimes these might be associated with nerve or neural sensitivity as well. So if someone has an associated neck condition, then that may be impacting the neural sensitivity down into the elbow. So we may include some neck treatment as part of the management strategy as well. So this episode has been a little longer than I expected. It's been a lot longer than I expected. And I could probably dedicate an individual episode to each one of those conditions. But I think understanding tendon pain as a whole is an important concept for people who may have heard of tennis elbow and golfer's elbow, or tendonitis, tendinopathy, but not quite understand that it's essentially the same type of condition. Although, as we talked about before, there are slightly different nuances to how we treat these different conditions. I think it is good to have an understanding of the role of the tendon in the production of human movement, and why it is potentially susceptible to a painful experience when excessive load is applied. So I hope that has been of use to people. As always, if you have any questions, please message them through to us. And obviously, if you're in the Tokyo area and you are struggling with any tendon-related pain, then please come in and allow us to try and help you. Thank you very much for listening, and I'll look forward to seeing you on the next episode.